Yes, 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 we can see you. Maryam, you can start.
هلا صباح الخير دكتور. Good morning everybody. It's my pleasure to be with you here today. Our case today is endosleeve gastroplasty. We'll start. For sake of time already we are inserting over tube and we will start it for this patient now. Please, you know. Okay, Excel please. Very good. I will not continue the diagnostic gastroscopy because all done before this procedure. Just I use it over tube guided by gastroscopy. And now I can see you the incisura, which is the site where I will start my first stitch from the posterior wall, gastric curvature, and then anterior wall. Okay, you can see now.
But by the way, what kind of device are you planning to use for this procedure?
I'm using overstitch system from Apollo.
Okay.
Okay. Just 1 minute because we are switching the scopes. So endosleeve gastroplasty is one of luminal procedure. We are endoluminal procedure. It's a type of restriction procedure where we can reduce the cavity of the stomach, and this will can delay the gastric emptying, and it will increase the stay of the patient. Give me the switcher, please. I don't know if you are seeing the scope right now.
We are seeing the scope, of course.
Okay, it's overstitch system with handle and with helix and with curved needle we are using through the procedure. We are inserting the suture through the channel. What's good about this system can reload outside the patient and inside the patient.
Can you show the endoscopy image as well?
Yeah, just when we go inside. We are still out.
Hi, Maryam. It's Pradeep Bandari here. I was just going to ask whether you're using the overstitch, the Apollo SX, or you're using the conventional with the double channel scope.
Scope, that one, I think it's not reached to our region yet.
Okay.
Yeah.
By the way, when you use the Apollo system, it is necessary to use overtube all the time, or can you introduce this system without overtube in some cases?
Don't deflate. No, all the time I'm using the overtube.
Okay.
The light, please. Okay, so here's the incisura.
One comment, Professor Yahagi and Professor Badib. that Maryam is the only female physician in the Middle East doing ESG. Just a very, I'm very biased to Maryam. Huh?
Okay, Mustafa. Okay, so what we are doing, the plan now, we are taking the first bite here, okay, from the incisura, okay, then we are going down for the greater curvature, and then we are coming here again for another bite. Usually I'm using a U-shape suture, okay, helix out, 2, 3, okay, another one also, helix. Extend. Okay, this is the first bite. I'm loading the suture inside, going to the second, helix out, 1, 3. Helix out. Okay. Again. Helix out, 1, 2, 3. Extending, yeah. Good.
There is one comment regarding the condition of the stomach, because we can see lac on the surface of the healthy mucosa. Therefore, I guess that this is H. pylori negative stomach. That is very important information. Because if there is H. pylori,
so we are going, as I told you, it's U-shaped. So usually I'm coming here again. Helix out, 1, 2, 3.
In case of having chronic,
and usually we need to make sure that the mucosa is coming to us. Okay, helix. Okay, we haven't taken.
Maryam.
Okay, helix out. Yes, please.
May I explain the risk of cancer caused by H. pylori infection?
Yes, I'm hearing you.
Yeah, while you are doing some procedure. Because at least in our country, there are lots of H. pylori infected patients which already developed chronic atrophic gastritis. For instance of gastric cancer.
As I told you, it's a U-shape. So I finished now going to the right, helix out. 1, 2, 3.
That's why it is really.
We need, as I told you, to make sure that the mucosa of the wall of the stomach coming to us. Usually, if it's difficult to unheal.
So at least this patient doesn't have H. pylori infection and there is no chronic atrophic gastritis. It is completely healthy mucosa. That's why we can do gastroplasty using upper stage. Otherwise, there will be some risk of cancer development after the gastroplasty. That will be a very difficult situation. So we should check the condition of the mucosa before conducting this procedure. Don't you have any comment, Pradeep?
No, I think this is a very relevant point because I personally feel that patients undergoing this procedure should have H. pylori tested and eradicated if necessary. Because once you have the entire stomach plicated like that, it's very difficult to know what's going on in the mucosa, which is not accessible to us.
Yeah, that's right.
Yeah.
How is the incidence of gastric cancer in Middle East countries? It's not so high.
Well,
I can answer this question.
Yes.
I think this is one of our big defects, that we don't really have maybe in Egypt really numbers. Now it's better and better, because I think especially in maybe we have another countries like in Lebanon and like maybe UAE, they have previous than us high definition scopes and can see really lesion early. Egypt is now going on this track. But yes, I can see also Professor Asad Suwaid joined us. So good morning, Professor Asad. It's really our pleasure and my honor to have you. And also Professor Asad can also have a very good figure. Lebanon is one of the very well established countries regarding even database. So what's your opinion about the gastric incidence, gastric tumor incidence in the Middle East, Asad?
Good morning, Professor Musta. It's a pleasure being here. I know my session is not officially started, or my section is started, but your question was about the gastric cancer in the Middle East, correct?
Yeah. Yes, correct. Yes.
Yes. Well, I mean, we don't really have statistics, but we know that we do not see early gastric cancer as much as our colleagues in Japan, who are the experts in early gastric cancer. We have a lot of Helicobacter pylori. So we do see gastric cancer, but unfortunately, most of the gastric cancers we see are at a more advanced stages. At the end of the day, we also see things that are related to Helicobacter pylori, namely the mild lymphomas. We see quite a bit of mild lymphomas. But per se, gastric cancer, we do see it. We don't really have numbers. It's not uncommon, but it's not at an early stage like our Japanese colleagues see.
Okay. Thank you. Yes, thank you, Professor Suwaid. And I think Maryam is back to the stage. Maryam, could you show us your progression? Yes, you can see now that Maryam is continuing her suturing. Yes, we can see you, Maryam.
Yes, hi again. I finished the first row. I'm going through the second row now. Looks out. 1, 2, 3.
It's really surprising that you can swallow the gastric cord very fast. How long does it take for a single case?
It's depends. Some cases they are difficult. Some cases they are. Actually, I face problem with the patient who's having Botox for weight reduction, or patient who's having before gastric balloon. They have dilated stomach, so usually it's difficult for me and taking longer time. And helix. Otherwise, if it's straightforward, can finish fast.
And just a question, Maryam, when stop? So which means when you decide, okay, this is enough, and I will stop putting more sutures.
When I'm satisfied that it's I reach the tubular shape for the stomach.
Okay. So, Professor Bandari, you do also ESG in the UK?
Yes, we do. It's not that popular because it doesn't have a tariff on our NHS system. So most of these procedures are done in private setup. So the numbers are not that big, but it's picking up. I think it's a very good procedure, as Maryam is showing elegantly how quickly you can plicate the stomach. And for me, I think these procedures are all a continuum. You starting with balloon to ESG to laparoscopic sleeve to bypass. So this is just a continuum because none of the procedures are perfect, but they do buy time. The patients lose weight, and with time they begin to put on weight again. You move on to the next step.
Yes, I think this is the key point, that obesity, it's a lifelong disease. So obesity, it's not only a one-step solution, and this is always when I tell my patients that you are maybe indicated for a balloon today, but in 5 years you can do ESG, and then in 5 you can do sleep. So it's a lifelong thing. It's not about only one magic solution. We still don't have the magic solution.
Unfortunately, we are a little bit running out of time. We have to go to next session, but before moving to the next speaker, I would like to ask Maryam for the final comment regarding this technique. What is the most important technical tip?
I can't hear you. Excuse me.
Could you tell me what is the most important technical tip for this technique?
Excuse me, can you repeat your question again?
What would be, Maryam, your final steps now? Because we have to leave. What will be your final steps to do?
Final step. What I'm doing, it's like U-shape suturing, and every row consists of 4 to 6 bites, and usually it should be having the same result of endosleeve, laparoscopic endosleeve, by having a tubular shape of the stomach. Because as I told you, it's a restrictive procedure. The aim of this is to reduce effective volume of gastric lumen.
Thank you. So we have to switch to the next speaker, who is Professor Asad Suodi from Lebanon. He is going to show us contrast enhanced in US. This is recording session. Could you start your presentation, Professor Suodi?
Well, good morning, everybody. Let me first start by share my screen.
خلصنا؟